The Oxford Academic Health Science Network brings together world-leading organisations in healthcare, research and the life science industry, together with our public, to deliver sustainable, best care and in doing so create wealth in our region. We encompass Berkshire, Buckinghamshire, Milton Keynes, Oxfordshire and West Bedfordshire, with a population of 3.2 million and engage with surrounding counties. We have chosen clinical networks as the delivery mechanism of our AHSN. One of these is the Diabetes Clinical Network, which builds on the pioneering work of the Oxford Centre for Diabetes, Endocrinology and Metabolism, which was established in 2003 to develop new models of collaboration between the NHS, universities and industry for tangible patient benefit.
I think OCDEM is an excellent model for the Oxford Academic Health Science Network because of its three component parts, because it incorporates a very close partnership between the NHS, between industry and between academia. My understanding of the AHSNs is that's what they're all about. It's bringing together partnerships.
We have not only looked at developing innovative products for people with diabetes, also we're looking very carefully in everything we do after the well-being of people with diabetes. In this respect, we have to make sure that we translate research into good clinical practice as well. And that is what exactly one of the objectives of the HSN, to make sure that people with diabetes do get the right medicine, do get the right education, to make sure that they can live basically happily with their condition.
We were longing from the industry to get some partner with the market we serve. The challenge for us has been, how do we adapt these learned practices from one hospital into other areas? A company like BD could bring a lot of value to the market we serve. There is an opportunity for more investment in R&D in our company. I think this could expand. If I could present to my company that there is a network in place who represent a lot of value and can, buy their professional skills as well as good outcome data together with power to improve the diffusion in NHS, I think there would be an interest in our company to invest in R&D as well.
Oxford AHSN is also working with smaller businesses to develop innovative products in healthcare.
The principles that we're applying to patient self-management apply to all numbers of chronic diseases, but we want to start in a very focused way, and the first disease we're tackling is type 2 diabetes. And one way of framing it is to think about it in terms of the 8,760 hours in a year. And the typical patient with chronic diseases in the United Kingdom will spend 3 hours in front of a healthcare system, so in front of a doctor or a nurse, and 8,757 hours essentially looking after themselves. Do they take their medication? Do they attend their follow-up appointment? Do they attend, if they've got diabetes, their annual screening for retinopathy to make sure they're not going blind? So there are any number of interventions that we expect patients to do for themselves. And yet if you look at the tools we're providing for patients currently in order to do that, it's fair to say they really are inadequate.
So I press GDM app, and here I have a menu of all the things I can do. So I would get my blood sugar meter. At that point I need to put the phone down because I need to prick my finger and get a drop of blood onto the meter. It then arrives into the phone. We have a clinical algorithm according to NICE, whereby if somebody has 3 high readings within a particular set period, they then have to step up their insulin to lower their blood sugars. So the software will look for a sequence of those 3 readings, alert the clinician, and then the patient will have a text message from the clinician to increase her insulin because she's been running too high. The beauty of this technology, because it's real time, you do that when that 3rd reading in the sequence of 3 arrives. You don't wait till the next clinic appointment, which may be 2, 3 or 4 weeks away. I think the best thing from the patient's point of view is reassurance, and to know that if you are really getting out of control, someone will call you and help you to get back in control. So the biggest word we have is reassurance.
Creating a better system of communication between patient and carers is crucial for best care and promoting self-management.
So the records that we have are any notes that are taken in OCDEM and any past letters, any communications that have been sent to OCDEM, but we don't have access to their primary notes that are based out in the general practices.
And so what we want to do is provide systems. There'll be e-health systems, so web-based and tablet-based and mobile platform-based systems, whereby patients will be able to get all the tools that they need to become much more actively involved in managing their own condition in partnership with their doctor or nurse.
The NHS Atlas of Variation, developed by members in our AHSN team, illustrates widespread variations of care delivery across the country. Reduction of such variation, when unwarranted, is a defining purpose of our clinical networks. One of our solutions in diabetes is the copying and adoption of models of integrated diabetes clinical care.
We can look at areas where we've got good healthcare delivery and areas where it's maybe not so good. And we will be able to measure and we'll be able to monitor how quickly we can bring other areas up so that we do get to a better standard of care.
We've been looking at a more integrated model of care, as many health authorities across the country have been doing, and getting the expertise of our specialist colleagues more readily into primary care, which has lots of benefits. Benefits to the patient, it also benefits from us in terms of closer working and education.
For integration to work, we need a common set of clinical information available to each patient and relevant carers, and good linkage between databases held in different sectors.
There is still a fairly significant division between primary care and secondary care. And by that I mean that I have kind of parallel relationships, one with my GP practice and one with the diabetes clinic. Although there is an information exchange, it's two separate bodies who are essentially trying to get to the same destination, but they're on separate buses. and I kind of hop on one and then hop off and so forth.
We tend to just use whatever blood glucose records people keep, and it tends to be in a wide range of ways, from notebooks to scraps of paper to on the back of newspapers. We'll go on whatever the patient brings.
At the moment, there are organisations across the network that are facing the same challenges in terms of accessing, acquiring new data, managing that data, linking that data, and analysing it. Because we're all facing the same challenges, there's a lot of scope for working together, joining forces and joining data to tackle them.
If there's one set of results and they're stored in one place and people have access to those, then there's an economy of activity and so forth. And I think that would be quite beneficial to both myself and the NHS, I guess. And since I'm a stakeholder in the NHS and being a taxpayer, I'm also a customer. I think that would be all to the good.